All right, good afternoon, everybody. Welcome to today's meeting of the Adults and Communities Overview and Scrutiny Committee, which is taking place at County Hall in Glenfield. Though some of our officers may be joining us by Microsoft Teams. I would like to remind everyone present that this meeting will be broadcast live via the County Council's website and will also be available for viewing after the meeting. Can everyone please switch their microphone on when speaking, then turn it off when finished speaking. Now, one of our committee, Linda Broadley, is chosen not to join us today because she's suffering from the flu, and I'd like to thank her for putting the health of this committee above her own, but she is hopefully intending to join us on Teams. I don't know if she's managed it yet. I know she's struggling with communication issues, but I'd just like to give past my thanks on to Linda for taking that step, particularly in current times. Agenda item 1 is minutes of the meeting held on the 6th of September. I propose that the minutes of the meeting held on the 6th of September 2021 are taken as read, confirmed and signed. Does everybody agree? Thank you. Agenda item 2. I've received no questions from members of the public. Agenda item 3. Questions asked by members under Standing Order 7.3 and 7.5. I've received no such questions from members. Agenda item 4, to advise of any other items which the chairman's decided to take as urgent. I've been notified of no urgent items. Agenda item 5 is declarations of interest in respect of items on the agenda. And I know Amanda Wright has a declaration she wishes to make.
I'll just make my normal general declaration of interest in terms of my work with the NHS and also with care home providers.
Thank you, Amanda. Do any other members have any declarations they wish to make? Right, thank you. Agenda item 6, declarations of the party whip in accordance with Overview and Scrutiny Procedure Rule 16. I've had no such declarations. Agenda item 7, presentation of petitions under Standing Order 35. No petitions have been received. So I think the first item on today's agenda is engagement on the Council's strategic plan that's set out on pages 13 to 64 of the agenda pack. Mrs. Posnett, the Cabinet Lead Member for Community and Staff Relations, will introduce the item before handing over to Ashley Epps, Senior Policy Officer. Just before I ask Pam to do that, can I just remind members that this report will be going to all Scrutiny and Overview committees. So we're here today just to look at those matters as they relate to this committee, or matters which have an overlap across this committee and others, rather than look at the whole report. So over to you, please, Pam.
Thank you, Chairman. I'm pleased to be the lead member for this strategic plan. I think it's something that the Council are really thinking about, including other people, and working, officers are working really well to set up this plan. It sets out the Council's long-term vision and aspirations, along with its aims and actions for the next 4 years. The plan is based on 5 broad aspirational strategic outcomes which reflect the Council's broad range of responsibilities and its significant capacity to influence residents, community groups and partners. The strategic priorities and objectives of the Adults and Communities Department are embedded throughout the plan. I look forward to hearing more about this and will now hand over to Ashley, who will do the presentation. Thank you.
Thank you. So yeah, thanks for having me today. So the report provides an update on work to refresh the Council strategic plan and seeks the views of this committee on the draft plan. So a 12-week public consultation is currently underway and will run until the 21st of January next year. So as Mrs. Posnett mentioned, the strategic plan sets out the Council's long-term vision and aspirations for Leicestershire. The current plan, covering 2018 to 2022, was signed off by the Council on the 6th of December 2017. A revised version of that was reflecting the Council's declaration of a climate emergency was then approved on the 8th of July 2020. That plan still covered up till 2022, which has led to the work this year to update and refresh the plan. So the draft plan covering 2022 to 26, which is in the appendix, has been developed through engagement with corporate management team members That's included a comprehensive review of the Council's performance and the national policy context, along with analysis of the priorities and deliverables set out in existing Council and partnership strategies. The plan is based on 5 strategic outcomes which describe the Council's vision for Leicestershire, and each outcome includes 4 or 5 sub-outcomes which will need to be achieved to deliver the main outcome. As Mrs. Posnett said, these outcomes are broad and aspirational, so to ensure that the plan provides a clear strategic direction for the Council, it also includes the specific aims and actions to deliver each outcome over the next 4 years. And those actions have been taken from existing Council plans and strategies. In addition to the outcomes, aims and actions in the plan, the plan also includes a section on enabling services, which highlights the contributions of back office functions like finance, human resources, IT, to outcome delivery and sustaining good governance. There's also a section on the medium-term financial strategy, which sets out the Council's aims and actions to maintain a balanced budget while protecting frontline services. And there's a section on the strategic change portfolio, which sets out the aims and actions of this internal transformation programme. So the outcomes in the plan are intended to broadly reflect the remits of departments and the portfolios of lead members. So, for example, the improving opportunities outcome is very much children and families focused, whereas the keeping people safe and well outcome also covers a significant proportion of adults and communities priorities. Successful delivery of the plan will, however, require departments sharing ownership of all outcomes, in addition to those outcomes being reflected in all relevant Council plans and strategies. So just briefly, the outcomes are, the first one is a clean green future, which is a new outcome covering the Council's aspirations to tackle climate change, biodiversity loss and unsustainable resource usage. Great communities covers equality and diversity, community engagement, community resilience, the enjoyment and preservation of cultural and historical heritage, and people supporting each other through volunteering. Improving opportunities is also a new outcome focused on supporting disadvantaged children to aim high, to access the opportunities they need to aim high and reach their full potential. Strong economy, transport and infrastructure is an expanded version of the former strong economy outcome, which now includes sort of infrastructure, including ensuring we have excellent transport connections and digital connectivity, as well as covering our ambitions around housing. And finally, the keeping people safe and well outcome is a merger of 2 former outcomes related to community safety and well-being. So it covers people being safe and well in their daily lives, as well as our safeguarding duties to protect vulnerable people, and ensuring that carers and those with care needs are supported to live active, independent and fulfilling lives. So our progress in delivering each of these outcomes will be monitored by outcome boards consisting of representatives from each of the Council's departments, in addition to a chair from corporate management team. The boards will meet on a quarterly basis to review a summary of performance and delivery related to their outcome. They will then contribute to 6 monthly highlight reports for corporate management team, where they'll set out key achievements, challenges and improvement priorities related to that outcome. Scrutiny committees will also receive quarterly updates on our performance related to each outcome. The outcome boards will also have the ability to review and inform the development of Council plans and strategies. So any strategy that's being developed, the board could essentially sort of call that strategy in for review and provide recommendations to help ensure that the strategy reflects the aim of their respective outcome. So just quickly in terms of the content related to adults and communities. So the report highlights from paragraphs 11 to 15 areas of the draft plan in which the aims and actions of adults and communities department are reflected. The outcome with the most direct links to adults and communities is keeping people safe and well outcome. However, the aims and actions of adults and communities are also embedded throughout the plan. So just a few examples of that. So the improving opportunities outcome includes, for example, for sub-outcome 7.4, everyone is able to aim high and reach their full potential. An aim and supporting actions to ensure that disadvantaged adults, such as those with learning disabilities, mental illness or and or autism are in paid employment and living independently, so the percentage is higher than the national average. The strong economy, transport and infrastructure outcome highlights some of the ongoing recruitment and retention difficulties facing the social care sector, along with actions to work with partners to address skills and labour shortages. And that outcome also includes, for sub-outcome 8.5, the right homes in the right places, actions to meet the accommodation needs of social care service users, including disabled and frail people. The plan also highlights the significant contributions of adults and communities, adult learning and community wellbeing services. So the Great Communities outcome includes, for sub-outcome 6.4, around cultural and historical heritage being enjoyed and conserved, an aim to increase the number of Leicestershire residents and visitors engaging in cultural and heritage activities. And that's supported by commitments, including for the council's libraries and heritage sites, and adult learning services to provide free and accessible facilities, exhibitions and learning opportunities, and for the audience development team to support communities to engage in cultural activities and develop their own programmes of cultural events. The role of those services in supporting resident wellbeing is also highlighted under the Keeping People Safe and Well outcome, particularly sub-outcome 9.3 about people enjoying long lives and good health. So in terms of the Keeping People Safe and Well outcome, as I said, there's significant links between that outcome and the Adults and Communities Department. So, for example, under sub-outcome 9.2, that sub-outcome covers the council's duty to safeguard vulnerable people. And one of the key aims is to ensure that safeguarding approaches are effective in recovery from COVID-19 and informed by lesson learning from the pandemic. Specific actions include identifying and responding to hidden harm, sort of neglect that may have been hidden during the pandemic, supporting care homes, risk assessing and quality assuring providers, and reviewing safeguarding lessons through our Leicestershire safeguarding boards. A further aim related to that sub-outcome is about vulnerable people being identified and protected, which includes actions to work with communities to prevent people from becoming victims and to ensure that they know how to seek help and have the confidence to do so, as well as actions to combat specific issues like domestic violence and protecting survivors and their families in a safe accommodation. A further sub-outcome with particularly strong links to adults and communities is 9.4, which is about carers and those with care needs being supported to live active, independent and fulfilling lives. That's on pages 37 to 38 of the draft plan. So that includes the following aims. So there's an increase in the proportion of people who find it easy to access information and advice about adult social care services. And there's actions to support that, including a more digital approach to providing information and advice, providing proactive advice around housing to enable people to plan for their futures, and providing effective information, advice and guidance around dementia support. A further aim is for improvements in the experiences of those who receive adult social care services. So actions to support that include ensuring there's effective integration between health and social care, so there's seamless service delivery, supporting people service users to sort of choose their own care through direct payments and personal budgets, enabling self-reliance through effective crisis response, reablement, equipment and technology services, and working with providers to maximise opportunities for well-being and independence for their service users. And finally, the final aim for that sub-outcome is carers are recognised, valued and supported to undertake their caring role whilst maintaining their own health and well-being. And actions to support that include working with partners to identify and signpost carers to support, engaging carers in service development, developing carer-friendly communities and promoting health checks for carers. So as highlighted previously, a consultation is now underway on the plan. And as mentioned, all scrutiny committees and the Commission, as well as key partnership boards, will be invited to comment. Residents, community groups and partners will also be engaged through a public survey which is now live, and meetings with community groups and partners. Once the public consultation ends on the 21st of January, we will analyse the feedback and incorporate it where possible into a revised version of the plan. Key findings from the consultation will be set out on the Council's Have Your Say pages, and a final plan will be presented to Scrutiny Commission and Cabinet in March next year, followed by County Council in May. Thank you.
Thank you, Ashley. Who wants to go first? That was Champion.
Thank you, Chair. Yeah, referring back to this sub-outcome 8.5, which is the meeting the accommodation needs of the disabled, etc. I'm just thinking, if, you know, in my other role as a district and as chair of planning, I'm dealing all the time with the housing officer. We're looking at the head, and looking at the mix of affordable housing. And we're determining that on what housing we need for the families that need housing. So where you've got these accommodation needs, you'll have special requirements in ramps, etc., wet rooms, that kind of thing. I can't ever remember ever seeing county ask us to discuss with the developers to put this in at the build stage. Is that something, a trick we're missing here? Because if you let us know what you want, that could be filtered into the development.
Yeah, thanks. Yeah, I think I may need to sort of get back to you on that one, if that's okay, because I'm not entirely not very close to that kind of area of work, sort of development work. So yeah, I'll definitely get back to you in response to that. Thanks.
Ms. Wright.
In terms of the paper, it talks about resources implications, and I was kind of interested in that, and now my computer's just died on me. But the resource implication essentially says that all of these actions anyway have been funded by other services. And if you could just have a look at that section for me, since I can't pull it up now. Ah, excellent. Yes, it says all actions within the plan are from existing service business plans and strategies. As such, there should not be any additional resource investment required to deliver the plan. If all of the actions within this plan are from existing service or business plans and strategies, then why haven't they been implemented before?
Yeah, thanks for that. So I think when it refers to sort of they're from existing plans and strategies, it's sort of those plans and strategies that cover the next within the next 4 years. So it's actions that will be delivered over the course of this strategic plan. So yeah, all the actions in the plan are from strategies that are covering the next sort of 4 years. Or
then why are we putting them in another document if they're already out there in different guises?
Thanks. Yeah, it's just because the strategic plan, essentially, its main purpose is to sort of summarise the council's strategic vision and aspirations. So it kind of forms a strategic framework for the council and sets out all of its activity in a single kind of document, and through that identifies the specific priorities that we need to focus on. So the aims in the strategic plan aren't always from existing strategies. They're from a combination of the content of existing strategies as well as sort of our own analysis of performance, strengths and weaknesses. But the actions are just those that we've already committed to support each of those aims.
I'm not sure whether that answers my question, but I'm happy to have a discussion outside this meeting on it.
Mr. Mayor.
Thank you, Chair. I think it's a well-written document, actually. There's a couple of things on the document I just wanted to point out, especially it's in relation to us. It refers to service users, customers, and I think if I look back at my mum won't think she's a customer of Leicestershire County Council. She'll just think she's a resident living in Leicestershire. So maybe the terminology there, we're not a business, let's be honest, we're not a business. So maybe we could change some of those customers' terminology to actually residents or whatever the word might be, a softer word. And I'm just thinking that we know exactly where you're coming from, but people out there who are accessing the service just see the council as the council, not as the business, and as a provider of services, which is good, which you know, they think they pay their council taxes for. That's why we're providing the services. And I think that's just a small point. But I think it's a really well written document. It's clear. And I really do like what it says, what will success look like, because that people can visualize what success will look like. And I know this is the next item on our agenda, which is digital developments, but I think that should be in there, because I think people have smartphones now, have iPads, access to that. Even my mum has an iPad. So maybe put that in that document when we're looking at 2022, 2026, to say that actually we are looking to transform adult social care so people can access it more. And I know there's one line about it, but it's hidden in the terminology, and I think it should be more to the forefront, because actually who accesses care for my mum, it's not herself, it's my sister, who's similar age to me, and she's au fait with technology. She will access it through whatever means we provide. So it's actually sometimes not the actual person who accesses social care. It is their family members who we should be tailoring this to, I think. And I think that's the point I was going to make in the next one, but I thought it would be good for this document as well. Thank you, Chair.
Anyone else? Oh, I shall sneak in then. I think just taking on the point that Mr. Champion's made, I think it would be good if in the document it strengthened the bit about accommodation. I mean, it says here on paragraph 12.8.5, doesn't it? It says includes actions to meet the accommodation needs of disabled and frail people. What we're talking about is actually getting ahead of the curve, not actually retrofitting properties, but actually making them available at the start. So in terms of dementia-friendly extra care facilities. So, and again, whilst we appreciate the County Council are not the planning authority, they do own significant parcels of land which could actually be used as the seed money almost to implement those sort of properties, providing that viability test. So I think a strengthening of the wording in the strategic plan on, accommodation, because we know that accommodation throughout life is one of the biggest backgrounds to having a healthy life and existence going forward. A couple of other things I've just mentioned. You mentioned about the outcome boards and that there'll be quarterly reports back. I would assume that surely each portfolio holder should be on one of those outcome boards. It seems strange to have outcome boards that have no member involvement. So I think certainly I would have thought the portfolio holder should be involved in those. And the last one of my pet ones, you'll get used to this if you come again, actually, is under paragraph 13, it says libraries and heritage sites providing free and accessible facilities. Accessible can be used in two ways. Can it mean getting into the building or actually being able to get to the place? And one of the things I continually bang on against, and John knows what I'm going to say now, is that we need to make sure as a county council that we do have sites available across the county, spread geographically, not concentrated if we can avoid it in certain areas, so that every resident of the county can actually access those facilities. So if you just look at our museums, for instance, we have areas of the county which have nothing near them for a museum, whereas we have other areas where you can go to 4 or 5 heritage sites within the stone's throw of each other. So again, I think something within the plan for a wider distribution, so that all residents can enjoy what we have here at the county, which is exceptional. And I think I would greatly appreciate. And on my final point, when you talk about public consultation, you didn't mention perhaps about using the biggest area for public consultation, which is our 3rd tier of parish and town councils. Because if you really want to get a message out, the quickest way to get a message out across Leicestershire for those areas that have them are through your parish and town councils. And I'm not aware that I don't know if you've written or will be writing to all parish and town councils, and perhaps even offering someone to go and talk to them. And then they would probably, I'm sure, get members of the public to come in. Sorry, Pam, I know you want to come back before Ashley.
Yeah, well, what I wanted to say was it Barry who asked the question? Yeah, we should be encouraging developers to build houses for life. I've been banging on about that. I'm on the planning committee. Well, I chair the planning committee at my own borough, and I keep banging on about houses for life to developers. You don't necessarily get a wet room, but you get accommodation which will be easy access for wheelchairs. There'll not be steps outside. You'll have a bathroom, there'll be a bath in it, but underneath the bath will be a shower platform. So when you can no longer get into the bath, then the bath will come out and the shower's already there. So they are things, I mean, we can't say to developers, we want you to build X number of houses on this site with wet rooms, because we don't know if people are going to buy them that need that sort of facility. So I think one way to start the scheme is houses for life, which I've been, since visiting some, I've been a great advocate for. So I do think that is sort of really important. And the other thing I just wanted to say about getting in touch with other communities, part of my other role, my portfolio, is I've got the communities as well. So I engage with parish councils. I don't think you can mention a community that I don't have some sort of engagement with. So yeah, the message will be spread throughout communities. Thank you.
Look forward to seeing you on the third Tuesday of the month at Narborough, Pam. Did you want to come back on any of those points, Ashley, before I call in Mr. Chair?
Yes, please. Yeah, thank you. Yeah, so on the first one around sort of the use of the word customers, I think that was terminology that we use for the strategic change portfolio sort of program, transformation program. But yeah, more than happy to change that, because I agree it's potentially best to use sort of service users and residents rather than customers. And yeah, more generally, there's a theme throughout the plan around sort of, although digitalisation of services is clearly happening and it's reflected in the plan, there's also recognition about the sort of potential issues of digital exclusion. And I think some of the actions that we'll have to address that issue will sort of arise throughout the 4 years. It's sort of a sort of growing area, I think, of activity. So yeah, I think that was everything I was going to say on that. And on accommodation, yeah, we can certainly strengthen the references to accommodation as well. So I'll definitely look into that, because I agree it's obviously a key area for service users. Accessibility as well. I'll look into sort of strengthening references to how we improve accessibility for everyone in Leicestershire and ensure there's a dispersion of sort of services throughout the county that people can access. Lead members on the outcome boards. I think I might need to go back and sort of talk to I don't know, my manager and the assistant chief exec and things like that, but I think it sounds a good idea. And finally, just on parish and town councils, yes, as sort of Ms. Posnett said, we're definitely engaging them directly. So we've got some items coming up in their newsletters and sort of round robin emails, and we'll be inviting them to feed into this public survey and offering to meet with them directly if they'd like. So.
Thank you for that, Ashley. And just on that thought, I mean, if the county council made use of the free newspapers, I mean, we've got the Journal in my part of the world. You get an advert in the Journal, you'll get 3 million responses. But I've never seen the county council ever put anything in the Journal, which meets, which hits 90% of the area I live in. Mr. Chapman.
Thank you, Chair. I'm just picking up actually on Mr. Champion. and think his comments is I, as well, am a vice chairman of the planning committee of one of our things. And where it's pointed out about wet rooms and that, they're actually starting to be put into houses more and more regularly because they're more desirable now. So all they've got to be done is made slightly bigger to start with, and we're already there. It's not a massive change to involve the planning authorities into this already, in my opinion. So I think it'd be a way forward to start working with them going forward. Thank you.
Has anyone got anything else? No? Right. Thank you, Pam. Thank you, Ashley. Pleasure to see you. We hope you'll come back and visit us again. I don't think I recall you being with us before unless I was asleep that day, but I'll try and stay awake. So that was very enjoyable. Thank you very much. We now move on to agenda item 9, which is a presentation on digital developments as set out in pages 65 to 84 in the agenda pack. And it's with John.
Thank you, Chair. I'll just try and bring up the presentation.
Sorry, I was just.
Might just take a second or two. So what we want to do this afternoon is just to give a very high level presentation of some of the work that we're undertaking in the department around digital development, which is obviously a topic conversation we just had in relation to the strategic plan. So it's quite fitting, really, isn't it? It's almost as if we'd planned it. So whilst it's loading, and it says we're having difficulty. Oh, well, there we go. I can wait a little bit longer, it says. I might need Lauren to see what's going on here, but You got it? Yeah. Right. Okay. Thanks. So this is just a very high level. There's quite a lot of work going on in the department around digital developments. We have a part of our adult social care strategy is devoted to digital and preparing us really for where we need to be over the course of the next few years. So this presentation is just to allow committee to ask any questions around the direction of travel, or if there are things that I'm going to be touching on at a fairly high level, if there are things that you want to bring back and have a more detailed discussion on, then we can do that as we go through. So we have a digital strategy which has sort of 5 different areas: customer facing, workforce, integration, systems development, and when we put horizon scanning, it's sort of looking to the future in terms of where we would need to be, positioning ourselves around some of those areas that we know we need to develop to improve our customer services and our customer access. Just want to focus on 3 of those today. So we're not going to look at workforce and we're not going to look at the systems, because the systems bit is kind of a bit techie, if I'm honest. And you probably wouldn't be as interested as you are in terms of how it's going to impact on people. So the first of those areas is customer facing. Previously, we brought reports through to committee talking about the work that we want to do with Hampshire County Council around the delivery of care technology, or technology enabled care, as it's sometimes called, TEC for short. We took a report through Cabinet to seek agreement for developing a strategic relationship with Hampshire. Hampshire are pretty much regarded as the #1 authority in the country around technology enabled care. They've done a lot of work in this area. They are very well respected. They have a partnership with a company called PA Consulting, who deliver their technology for them or with them. And we've developed a relationship with Hampshire. And the relationship is a sort of a hybrid model of delivery, whereby officers at the county council here will be responsible for much of the delivery, the assessment of the care needs, the assessment of the technology needs, the installation of some of that technology. But Hampshire and PA Consulting will provide us with leadership, transformation, cultural change. They'll guide us and work with us to ensure that we've got the right offer in place for people and to make sure that we've got the right kit and technology available. And they'll work with us over the course of the next few years to really start to challenge our thinking around the art of the possible in terms of what we can do. So what we've got at the moment is just a sort of a bit of a chart that sort of with the ticks kind of shows where Hampshire will be kind of leading and where Leicestershire will be leading. And again, the next slide goes into that in a bit more detail around sort of how the relationship that we're developing is going to work and how it's going to operate for the benefit of people in Leicestershire. Much of the work that we do with Hampshire will be around providing technology in people's own homes. So it'll be about keeping people as independent as they can be, trying to avoid the requirement for, particularly for older people, to require 24-hour care or try to avoid hospital treatments wherever possible. But there will also be some specialist work that we will do. So Hampshire have identified a number of areas where they think that outside of that kind of mainstream technology in people's homes, there may be some areas of benefit which might be a bit more specialist. So the first area they're going to work with us on will be learning disability supported living, where people receive support in their own homes, but quite intensive support, and Hampshire have done some good work with people in those situations to provide them with technology that enables them to be more independent. And then there are other areas around sort of dementia care, particularly care pathways around hospital discharge or hydration, but also wanting to make sure that we use the sort of the mainstream technology as effectively as we can. So this isn't all about specialist equipment and specialist kit. Much of this will be sort of thinking about what the possibilities are with the sort of the mainstream assistants like Alexa and Google and the ones that people have in their homes already, and how we can make best use of those. So that's kind of where we've got to with the work with Hampshire. It has been slightly delayed. We were hoping to start in April this year, but we are now at the point of starting that work and kicking that work off. The other area of customer-facing technology that we want, and digital that we want to develop, is our online presence. So we already have a portal as part of the County Council's website, which allows people to go online, start to undertake self-assessments, whether that's a carer's assessment or a financial assessment or a care and support needs assessment, Care Act assessment. Those assessments are already there on the council's website. They're not used particularly well in the main. It's a very small percentage of people who currently use those assessments and use that technology. And partly we think that's because it's perhaps not as easy to use as it could be. It perhaps needs to have a little bit more of a customer focus around it. It doesn't necessarily quite look the same as it would if you were perhaps going on to I don't know, an online banking site or an online supermarket or an electricity company, where we perhaps just need to develop the interface a bit more to make it look and feel like a tool that people would want to use. But we also need to think about how we promote that within the council. So are we really kind of transforming the way we work with people and the way that we engage with people in a way that would give people confidence that they could use those tools effectively? So there's some work that we need to do there. We know we need to do that, and that's the work we want to do over the course of the next 12 to 18 months, so that those tools that are available are tools that people would recognise and would want to work with us on. And it allows people to be much more involved in their assessment, co-producing the assessment that we do with them, being much more involved in their support planning. And of course, the logical extension to that then is that it allows us to develop what might be called customer accounts. Take the word customer and note the previous conversation. But where people could have care accounts with the council. So we could have two-way communication. People could access information that we hold on them whenever they want to access it. At the moment, all of that information is based within our kind of databases and our systems that we use to our financial systems. But there's no reason why over time we couldn't make that more accessible to people, so that people can have access to their invoicing online rather than waiting for the council to send them an invoice through the post, so that people know where they are in relation to any contribution that they need to make to their care. People be able to have two-way conversations digitally with us that they can't do at the moment. So it's quite a lot of development that we need to do in order to kind of bring ourselves into the 21st century, really. So that's the customer facing. Just a couple of slides around something called a shared care record. So this is part of the integration of health and care that we hear so much about. The government are very keen that by the end of this year, all health and care systems will have a shared care record. So this would mean that whether it's a GP or a hospital service or a social care service or a mental health service, people would have access to basic information about all of the services that people are receiving from all of those different organisations or providers. And if we were being asked to assess somebody for social care, we'd be able to just look up, know exactly what services people were getting from a hospital. We'd know exactly what the GP record was saying. It means that people wouldn't have to repeat that information time and time again. It means that we could be much more responsive. I think in the main, most people think we have this information already, but actually we don't. So this is something that we've been very keen to develop over a number of years. The government are investing heavily in providing the resources for this to happen. In Leicestershire, we are working with our local health partners, and we are developing this sort of single kind of front end record. It won't have all, you know, we're not going to have access to everybody's kind of health histories, but what we will get is sort of basic information about the treatments or the medications or the services that are being provided. We're using a tool called the Yorkshire and Humber Care Record. So this is something that's been proven. It's been developed, as it says, on the tin in Yorkshire and Humber region. And it's been proven to work, and it's been proven to be safe, and it's been proven to be secure. So rather than trying to reinvent that wheel, we are working with Yorkshire and Humber to develop that same tool in Leicestershire. And then the final area is the sort of the horizon scanning, which is also a little bit around customer facing. And again, it sort of links back to some of the conversation we had on the strategic plan. So a few months ago, we put a submission in. There was a national award, which was being run by the Association of Directors of Adult Social Services together with Microsoft. And they asked for submissions and bids to be put forward for work that might benefit not just people in Leicestershire, but nationally, have national benefit. So we put forward a submission which was accepted, which was to develop a what we're calling a care and support, a digital care and support worker. The notion is that people would be able to find information and advice much more readily, much more quickly than they can currently, and that we will be able to target advice and information at individuals rather than just sort of having to put everything out there, and then people having to wade through and try and find their way through, which is quite a maze of information when you think just about social care, let alone healthcare. So what we're looking to develop is something which would enable people to interact with a signposting service. And what we slide there, it was very complicated. It is very complicated. That's just a range of services that people, or a range of areas or information or advice that people might be seeking. How people navigate that currently is, most people will go on the council's website. They'll make a few clicks. They won't find what they're looking for, and they'll stop. They might then ring the customer service centre, and we get 35,000 contacts a year for adult social care through the council's customer service centre, so over 100 calls a day. Not all of those calls get answered. Not all of those calls get answered first time. People hang on, people don't hang on, and people give up. So what we want to do is develop a system whereby we can target information advice to people, make it relatively easy for people to find the information they're looking for through a digital platform. It's early days. We've only been doing this now for a couple of months, so we're still in the kind of developmental stage. But here's a sort of an example of the sorts of things that people might want to know. So if somebody wants to continue to live independently in their own home, what are the sort of questions that they might want to ask? What are the sort of services that they might want to find out about? How can we help them do that? How can we help them navigate the maze? The notion is that this care and support advisor will be able to direct them digitally into those areas directly that is of interest to them, but also the more times that people contact us, the more we can target the information, the advice that we give, because we know what we've said to them before, etc., etc. So that's something that we're working on, and is sort of I suppose, something for development next year and the year after. But is, I think, quite exciting if we can develop this. It's not something that is available nationally currently, which is why Microsoft and ADAS are keen to work with us. So that's a sort of a whistle-stop tour of some of the digital work we're doing, but I'm happy to answer any questions.
Mr. Champion.
Thank you, Chair. John, I suppose that the big thing with this is obviously it's the end user's got to use this technology. So what are we planning to do as far as the training is concerned to help them? Bearing in mind specifically the age of some of the people that we're we'll be targeting, and obviously they prefer to have that sort of thing shown to them in front of them rather than, you know, remotely. How are we going to cope with that side of it?
Yeah, I mean, I think that's a good question. I think the first thing to say is that it's not going to be the only offer. So this doesn't replace what we do now. So we still have the customer service centre, we'll still have the telephone numbers, we'll still have social care officers visiting people in their own homes, undertaking assessments with people, talking people through processes and what have you. This is in addition to all of that. And we know that there are some people who will always want to have that personal contact, and there are other people who actually would quite prefer to be able to do it digitally. And it kind of depends on, partly it depends on who it is that's contacting us. So although we get, as I said, we get 35,000 contacts a year, a very high proportion of those are professionals. So it's other professionals or health care professionals or other professionals who are contacting us and actually could quite easily and readily do that digitally. And would probably prefer to do that because they don't want to hang on telephones waiting for us to answer. I know there's a very high proportion are family members. So if it's about people like the mum or the dad or what have you, and those people are often more digitally connected. And some of those people work during the day, and when we're answering the phones, they're not able to make the calls. So it might suit them to contact us in the evenings and weekends and do it in a way that suits them. But equally, we also recognise that there will always be a requirement for there to be a personal call or a personal a person answering at the end of the phone or visiting the person. So it's not one or the other. I think it has to be both. And I think just increasingly people are just much more digitally competent now than, I mean, even they were 12 months ago. Most people live their lives, you know, the online bank, they do their insurance online, they do the car insurance online, they shop online. The only thing they can't do is they can't contact social care online.
Mrs. Broadley.
Thank you, Chair. It's very interesting. I've got to say, I don't do online banking. I don't do a lot of those things. I'm probably in that age group that is quite wary of the internet and everything because I don't understand a lot of it. I have managed to get on this team meeting, which is a miracle. And I'm pleased that you are doing that. This isn't a replacement for normal contact, because certainly a lot of elderly people do feel lonely, and going online, if they're capable, is not giving them that contact with another person. So even if it's them coming to us with a problem or wanting to know about something, it is like you say, there will still be the face-to-face contact or just speaking to another person on the telephone, which I think is vitally important. So I'm really pleased to hear that you've said this isn't a replacement, that it is just an extension. Thank you.
Mr. Chapman.
Thank you, Chair. You said this is going to be a derived system from someone else who's already using a system like this. Is that correct?
The shared care record, yes.
So what? I know you're only 2 months in, but what's your timeline, do you think, to actually have this up and running, or at least at a test stage to start trying it?
Well, I suppose it depends on which bit of the tech we're talking about. So if it's the shared care record, which is the single record across health and care, we should have that by the end of the year. The basics of that should be there by the end of the year. If it's the care technology, so the kit in people's homes, again, I mean, we do some of that now anyway. We're just not at the level that we want to be. But we'll be looking to roll that out over the course of the next 12 months to a much greater degree than we currently do. If it's the care and support advisor, the sort of the information advice guidance system, I think that's probably a longer burn. I think that takes some considerable time to develop that system.
Ms. Wright.
Thank you. Yes, I was going to ask about the shared care record and kind of the scope of that. I mean, we all know that the NHS tried and failed miserably to connect all of our systems together. I know of a couple of systems, including System 1, for instance, say that the GPs use and that can be accessed at points in time, and there are blood sets that can be utilised, hospital records, but none of it seems to join up. And I don't know how you can have this aspiration in terms of it when so much money is being put into it, billions and billions, in fact, and it failed absolutely abysmally in the past. So I'm not quite sure how you're going to do that, and maybe you'd like to explain in a little more detail, especially in terms of linking things in like social care, like mental health. You know, there's a lot of different parts to the puzzle. And it seems quite interesting. You're going to do something the NHS and billions later potentially couldn't.
Well, I suppose the first thing to say, I absolutely agree. And you know, the last, 10, 15, 20 years have been awash with, there was billions thrown at BT, I think, at one point to get the NHS just to integrate its data, let alone with anybody else. There have been various stop-starts along the way. The technology that we're using for the shared care record isn't new technology. So it's actually quite basic technology. What it in fact is, at its simplest level, is a data warehouse. And various systems, so whether it's System 1 is one of them. So System 1, which is used by GPs and is used by community health services, together with our own LES system, which is used by ourselves, by Leicester City and by Rutland councils, together with the systems that are used in UHL, which name escapes me at the moment, but it'll come to me, I'm sure. Effectively, all that happens is that data is pulled from each of those systems and put into a data warehouse. And then it's obviously got a unique identifier. It's got the NHS number. And then if somebody's sitting in a GP surgery, or somebody's sitting in a hospital, or somebody's sitting in somebody's own home, and they want to pull up data, they can just pull data out of the warehouse that relates to that individual and see it on their screen. What it doesn't do, what it's not, and this is partly why some of these systems have failed in the past, is that in the past, what we've tried to do is have live feeds and live updates in real time. I don't think that's going to be possible for this shared care record. So this will probably update, I don't know, every night or something. But what it won't do is give live feed. So if I'm typing into somebody's care record, what I'm typing in won't suddenly appear in somebody else's screen instantly. That's where most of those systems fall down, because you need a very, very complicated interface for that. What I also can't do is tell you all the technical detail behind it, because it's kind of not something that I'm particularly aware of. But what we can do, if it's of interest, is I can ask the people who are leading the programme to come and talk to us about exactly how they're developing it and what it'll do and what it won't do and what its limitations are, etc., etc. Happy to do that.
I think that would be useful. I mean, there's all kinds of issues, isn't there, regarding GDPR, how then you get clinicians trained up to be able to navigate this data warehouse, where the clinicians indeed will have the time to navigate a data warehouse to be able to use the information that potentially is in it. There's a lot of questions that arise from that. So yeah, I think something along those lines would be useful. Thank you.
Anyone else? Mr. Mayor.
I said most of what I was going to say in the previous article, but I just wanted to touch on one other point, which is the end user. And I think Mr. Chapman talked about we have to not lose sight of who our end users are on this one. And I don't mean in accessing technology, I mean in actually what do we want to achieve in this with this digitalization. If we want people to be able to navigate from instead of picking up the phone, but do it all online. That's great. That's if they can do it. And I know there'll be some challenges, especially in the BAME community, with that and with language barriers. But the other thing is also our whoever's going to access this. Our care providers, for example. So the people who bid packages. So I can see, not now, but maybe several years down the line, actually, we authorise care packages for a resident, and then they find their own care provider. We don't have to allocate it for them. For example, they say I have 12 hours worth of care a week. This is my budget. Who's willing to take that care package up? And I think if we can get to that stage, the council will be saving tens of millions of pounds a year. And that's if we can get to that stage. And I think that's what the exciting prospect is. Yes, it might be a bit iffy now, and we don't know what the outcome is going to be, but I think we have to have a vision. But the only vision will come is if we know who the end users are of this. And I think the two end users are our residents who actually in care packages, and ultimately the providers who are going to be providing those care packages. They're the two most important ones, because they're the two that we have to connect. And everybody else is accessing the system just to do their day job, really. And the other two people are doing it because one wants to provide a service and one needs a service. And I think if we can get those two together and cut out all the middlemen, I think we'll save tens of millions.
A rhetorical question, clearly. Thanks, Jill. This one from me, just at its basic level. Will we assist people in getting connectivity in their home? So if you haven't got the internet, for instance, will we look after that sort of thing for them? And if we thought creatively about this, I mean, we always go on about homes not having access to high-speed broadband, etc., which you don't actually particularly need for this. You just need a connection. And have we thought about working across the country with other councils? I mean, you know, the simple way of doing this is get people to just plug into their power grid. I mean, not most people remember that all the horse racing, etc., doesn't come over the internet. It comes down your power cables over the national grid. So have we thought about the directors talking to a major electricity provider and an internet provider about providing cheap access for residents so that we can actually make sure they're connected up?
So obviously we do have the programme, as that you're well aware of, in terms of rolling out the broadband connectivity across Leicestershire. We don't have anything in our strategy at the moment around supporting people with that. Although, having said that, and it goes back to the point that Mr. Mayor made, if a person has a direct payment for their social care, so we've assessed them and we've determined that they're eligible for X number of pounds worth of care a week. And part of that care requires them to have access to technology, and they don't have a broadband connection. There's no reason why you couldn't use your direct payment to install a broadband connection, because that would be part of your care package. If it's part of the support plan, there's no reason why you couldn't do that and use the money in that way. It's no different to, in a sense, asking, employing somebody to go and do your shopping for you. You're just getting a broadband connection so you can do your own shopping. So you could do that. You could use your direct payment to do that. Equally, other councils have and already are rolling out voice assistants, Googles, Alexas, all sorts of things as part of people's support plans. It's, 50 quid, 90 quid, however much it costs for an Alexa or a Google. And once you've got it, and if you've got a broadband connection, well, perhaps you can do your medication prompts on it. You don't need somebody to come around and prompt you around your medication. Perhaps you can do your meal prompts on it. Perhaps you can, there's all sorts of things you can do. You can, connect it up to your front door. You can have a door locking system. You can connect up to your lights, and you can do your lights on and off in the morning. You can connect to your cooker. You can turn your cooker on and off. And it's a £50 piece of kit. So, yeah, I mean, those are the sorts of things that we need to talk to Hampshire about in terms of where the benefit is, because that's the important bit. Is where's the benefit in all of these bits of technology? It's not technology for technology's sake, but if there's a benefit, why wouldn't you do it?
Thanks, John. Mr. Hill, sorry.
Thanks, Chair. Just one last question. I think all of this technology sounds very exciting and innovative, and we've got some great possibilities here. But to truly achieve all of those, I think feedback from the users is going to be absolutely key. So given it's in its quite early stages right now, what plans do you have to get feedback, not just at the start for implementation, but also ongoing? Because I think back to, you know, you may remember when Siri first came out, and actually it was a bit terrible. You know, it didn't really do anything you asked it to do. And, you know, you'd say, text this person, hi, I'm almost there, and it just have gobbledygook. But now it's a lot more reliable. So, you know, I think it's going to be an ongoing thing, getting feedback and tweaking the system. So what plans do you have for that?
Yeah, no, I think you're absolutely right. We do have customer groups that we work with, that we talk to existing customers and to carers. We will be doing that as we roll out the very bits of technology. We certainly wouldn't want to, particularly when you're thinking about things like the care and support assistant. Couldn't do that without actually talking to people and finding out from people, focus groups and others, about how that works. We have people who already go on our websites and test our websites for us, tell us what works and what doesn't work. And it's absolutely crucial as we go through this. There are, as you said, there's been significant advances in some of the technology that is already out there. And one of the points that Mr. Meir made, which was around, we need to make sure this works for the whole community, and particularly for people whose first language isn't English or who may struggle. Some of the technology enables us to translate information in ways that we couldn't now, without, you know, some considerable cost to the council or without going through third parties. I had one just last week, actually, where somebody required a translation and we didn't have the kit to do it. And we had to go out to a third party and ask them to do it, and we had to, you know, they obviously charged us for it, and then it takes 2 weeks to get the thing. So some of this is about just making things much easier for people, actually.
Thanks, John. I think it's clear from the comments of the committee. I think we're all very excited about this and see huge amounts of potential for our customers. Picking up on Jules' word, going forward, particularly if we can make it work in the best possible way. And I also sense, and members will tell me if I'm wrong, that I think we'd be quite keen to have some further information on the shared care record going forward. Would you like me to put that on the agenda for a future meeting for consideration? I think it seems quite keen that people are interested about that. So if we put that down on the future record, John, for going forwards, but I think we see this as only positive, and I think clearly Leicestershire are going in the right direction with this link up with Hampshire County Council. So we applaud the initiative and would always look to be supportive of it. So thank you very much for that. We're now moving on to agenda item 10, which is the current demand pressure on the Adults Communities Department forecast budget 2021-22, pages 85 to 94 in the pack. Back to John to give us the good news.
Thank you. Sure, that's a very good news report. I thought it was important, though, that committee had the opportunity to understand the current pressures that we are facing within the department and to ask any questions that they might want to around that. So it follows the reports that went through Cabinet, period 4 report to Cabinet, where we declared a £13 million overspend on the adult social care budgets, and subsequent conversation in full council. Background to where the demand pressures have come from is clearly linked to the pandemic. So this is these demand pressures have arisen post the kind of outbreak of COVID-19, and it's been I suppose a bit of a tumultuous period, 18 months through that period. What we found, and I think there's a chart at paragraph 8 of the report. What it shows is, oh, my screen's just frozen, sorry. What it should show, if I had a screen that worked, is when we started in April last year, the pandemic, thanks, Christine, we saw a very dramatic rise in demand for social care services, as you would expect. And that sort of peaked around about September of 2020. So that was sort of the first wave of the pandemic, the lockdown, lots of changes to the way that health services were being delivered, and that put a pressure on social care. That then began to be mitigated through the work we did with health services and with others throughout the sort of the autumn and winter. And you can see that the demand curve then started to come down through that period. And it was sort of around about November, December, where the council sort of starts to think about its medium-term financial strategy for the following years and starts to think about growth and what's happening with service demand. So at that point, we were kind of looking at a downward curve and thinking, actually, given the uncertainty around COVID, given we didn't know exactly what was going to happen with demand, and the fact that we were at that point receiving all sorts of additional funding through central government grants, through the NHS, through discharge processes, we took a decision at that point not to put any additional growth into social care until we properly understood what we thought the ongoing recurrent demand would be. So we just put the normal demographic growth in that we would in any given year at that point. And then what we saw was fairly unexpectedly, actually, around about February time of this year, we started to see some very, very significant growth in demand. And that growth in demand continued to rise throughout the first half of this year, certainly up until July, August. And of course, that covered that period 4 report, which went to Cabinet. And it showed that we got 2 issues developing. One was a very, very large demand for home care, outstripping anything we'd previously seen. And the other was that we'd got a very high number of people requiring temporary residential care. And that residential care was coming in at very high costs to the authority, much higher than we would normally expect to pay. So both of those 2 things created sort of a perfect storm in terms of a budget. But also what was happening was that the 2 are obviously connected. The growth in domiciliary care was largely due to hospital discharges. So hospitals were running incredibly hot. The Leicestershire hospitals were beginning to run incredibly hot from February onwards. The demand on hospital services was increasing week on week. What that was doing was placing quite a high pressure on the number of people who required social care on discharge from hospital. So our discharges from hospital went up from sort of, I think they were averaging around 90. Before that period, they went up to 120 on average. So a significant increase, 30% increase in the numbers of people coming out of hospital requiring social care. Home care provider, I mean, home care in a county like Leicestershire is tricky at the best of times. So we have always struggled to have sufficient capacity to meet demand because of the rurality issues, because of the economic issues in Leicestershire. But over that period, we've actually delivered 30% more home care than we've ever delivered before. So, you know, it's not a case that you often see sort of reported we've got less home care or we've got reduced numbers of home care. Actually, we've never delivered more home care. We were delivering just short of 20,000 hours a week pre-pandemic, and we're now doing 25,000 hours a week. That's, I mean, testament to the home care providers who have absolutely pulled out all the stops, I have to say. But there are limits, and they are now approaching those limits. So home care is becoming very difficult. It's at capacity as we speak. What that means is that the continued pressure to discharge people from hospital, increasing numbers of people from hospital, and not just the numbers, but actually the people coming out of hospital are coming out quite poorly often, and with much higher levels of need than they did previously. So what that's meant is that it's put a pressure on, if we can't get people home quickly then we tend to have to look to residential care options for people in order to discharge them. So the number of people in temporary residential care beds shot up from sort of a couple of hundred pre-pandemic to 700 at the height of this demand spike. Now around about 450, I think. But significant more numbers of people going into those temporary residential care beds at significant cost to the authority. And there's charts in the reports which kind of show you the numbers of people pre-pandemic that required residential care, temporary residential care, compared to the numbers that we now have at sort of paragraph 16. The impact that's had on the cost of care at paragraph 17. And there are the proportion of people who would have previously come out of hospital without the need for any social care involvement compared previously, pre-pandemic, to the proportion that now come out that don't require any care is halved. So all of this has meant that it's put tremendous pressure, not just on the ability to meet people's care needs, but also on the budgets that we have to meet people's care needs. And that's led to significant overspends in home care of up to 11-12 million. So a £20 million budget that's now at 30 million expenditure. Residential care costs have gone up by 6-7 million. Supported living costs have gone up by 2 or 3 million. Those costs are being offset to a degree by some savings in other areas, so particularly staffing, but some non-recurrent savings in other areas. We are trying to mitigate the effects, so we have a plan in place that is seeking to review everybody who is in receipt of home care, particularly starting with those people who have the high needs packages, so people who have 2 carers 4 times a day, to see whether or not those people could be more independent, to see whether or not any of that care could be delivered in other ways. We are putting in additional management and spending controls, so making sure that the care that we commission is the right level of care and that we're not over commissioning care. We're working with the residential care sector to look at whether or not the cost of care can be mitigated. There's a whole host of actions that we are taking to try and address the spend, and that is beginning to have an impact. So £13.5 million that was declared at period 4, by period 5, that had reduced to 9.8 million. And that will reduce again at period 6. Although having said that, the period 6 reduction will be significant. It'll be a £5 million reduction in period 6 to the overspend. But that reduction will be because the NHS, we've been talking to our NHS partners, and they have recognised the pressure that we are under, and they have recognised the difficult position that we are in. And they have found an additional £5 million in year that they have passed to us to meet some of those cost pressures. But that is a one-off, so that's not a recurrent £5 million. So whilst period 6 will look very good because it'll show that we're hopefully looking at a much reduced overspend, actually the underlying overspend is still at £10 million. So we continue to work on that, and we will continue to work on that for the rest of the year to look at where we can mitigate the spend and the cost. But the underlying trend will show that the demand for services is higher than it's ever been and is continuing to be such. The reviews that we have been undertaking, we've been doing about 50 reviews a week for the last few weeks. And they have been very successful in freeing up care hours. But equally, we have a very high number of people who are waiting for care and waiting to come out of hospital. And therefore, for every care hour we free up through the reviewing process, we're giving it to a new care user. So to make sure that people are getting the care in as timely way as possible. So that doesn't have impact on the budget, but it does mean that we are meeting people's care needs. There's a section in the report which talks about how we compare with other areas and if there's any difference between Leicestershire and other areas, and we've done a little bit of work on this. I think one of the things table in there, paragraph 28, does show that Leicestershire, being a low-funded authority, spends less than other authorities and has traditionally spent less than other authorities and significantly less than some of our comparator authorities. I think what that meant was that when the demand started to spike, we didn't have any cushion, if you like. We didn't have the sort of the cushion within the budgets that perhaps some other authorities might have had, and therefore it hit us quite hard. I think the other issues that are just highlighted in that section are that it's very difficult to compare. It's not necessarily an apples situation, in that different authorities took different approaches to COVID funding. So some authorities sort of front-loaded growth in this year into their service areas. Other authorities didn't. Some authorities have had more health funding than others, and it's kind of stark actually in terms of the variances in health funding that across the piece. Starting positions in terms of services differ. So rural areas find it much more difficult to find home care services than urban areas, and so when demand spikes, that has a bigger impact in rural areas. Our starting position in terms of some of our community health services was not the same as in some other areas. So, and it's been widely reported previously that we have insufficient community nursing services, we have insufficient community therapy services, we don't have NHS rehab beds in the same way that other areas do. So some of those things that would have taken up some of this demand aren't apparent in Leicestershire. Our reablement services have struggled with capacity, and we've struggled to recruit to them. And reablement is the most effective service in managing the amount of care that people require. So there are a combination of factors, I think, that have led us to the position that we're in, and clearly a number of areas that we need to, with partners across the health and care system, address. But the conclusion to this is that we have a higher level of demand than we have had hitherto. It is having a very significant impact on the adults' budgets, which in turn will have a very significant impact on the council's budgets. As we go into the next MTFS round, we will require a level of growth to meet that demand that has not been seen in the MTFS for some time. So I think 2015, we had around about £25 million worth of growth for adults in the council's MTFS. By 2019-20, that had come down to sort of 7 million. I suspect it'll be going back up towards where it was in 2015 in order to meet the current needs and the current demand. So that's going to have a significant impact on the council's finances for a number of years to come, I would think. I think probably leave it there.
Thank you, John. Miss Wright.
Yes, I had a general question really, and it's in relation to paragraph 28. And in this paragraph, it points out 6 different county councils, and it talks about the gross spend on adult social care 1920, and it puts us right at the bottom of the leaderboard, as it were. Now, obviously, that is a double-edged sword in many ways. Obviously, it is good that we are keeping, hopefully, costs as low as possible. But on the other hand, I, as a relative layperson, feel far more comfortable if we were in the middle of that leaderboard and not at the bottom, because a layperson looking at that paragraph is essentially going to think that we are not spending enough in Leicestershire on our elderly care. How do you address that if you are challenged on that point?
Turn the microphone on. So the first point I would say is that partly councils spending levels on adult social care or on any or transport or children's social care or any others are largely dependent on the amount of funding that those councils get. So if we were in Nottinghamshire or Derbyshire, for example, the councils that border us and they're in the chart there, we would have significantly more funding per head of population than we do in Leicestershire, which allows them to spend more. I don't know what the current figures are, but a couple of years ago it was in the region of £70 per head for Nottinghamshire and about £80 per head, I think, for Derbyshire. Difference between what they get and what we get. It's a significant amount of money when you're thinking of 700,000 people. Now, partly, of course, those funding allocations are based on a formula that the government use, which is all kind of connected to deprivation, it's connected to income, it's connected to all sorts of factors. As you'll know, our belief in Leicestershire is that we don't get fair funding, that formula is wrong, that it came out numbers of years ago. And that we believe that we should get a higher level of funding, but you can only spend the money that you've got. So what we do is we do everything we can to provide people with the services they need for the money that we have available. And as we've discussed here before, sometimes what that means is that if you were in Nottinghamshire or Derbyshire or North Yorkshire or one of the other counties in there, you might get a higher level of social care than you would in Leicestershire. That doesn't mean that we don't meet the needs of people who have eligible needs, but what it does mean possibly is that we don't provide as much as some others do. We believe that we have, through our strategic approach to social care, maintained people's independence. We have done everything we can to enhance people's independence. But we don't have the money to spend that some others do on their social care provision. And that's true for other areas of the council spending as well, frankly. And the charts there kind of show that. So if you were to look at the 1920 social care use of resources report, it would show you that Leicestershire, out of 151 councils that provide adult social care, were 151st in their spending on older adults. If you look at the 2021, which I got this morning, it will show you that we were 143rd, I think is what it says off the top of my head. So we were the lowest spending authority in the country on older adults. We are not anymore, but we're still fairly low. But that's because we also have the lowest level of funding in the country on it from any council.
Just in terms of the statutory responsibility in relation to social care, you're saying that we meet our statutory responsibilities, but there's meeting them, isn't there? And I know that quite a bit of money has gone into SEND from this council. Likewise, it's been very low funded, but we've found money from somewhere to go into this SEND pot. do you think that likewise adult and social care should be higher in the pecking order in terms of finding additional monies to support it?
Well, as I pointed out earlier, in 2015 we had a growth requirement of £25 million in the MTFS. It was the highest of any department. It was over half the growth of the entire council, actually. But through the strategies that we'd undertaken over that period, and by the way that we'd managed demand over that period, our growth requirement going into 1920 was £7 million. Now, that's because we had managed the budget successfully over that period. Not only had we managed it successfully, but actually in every single year between 2015 and 2019, we declared an underspend on our budget, which meant that we were meeting people's needs within the budget that we had available because of the way that we were strategically managing the care that people needed. Is it enough now? No, it's not. Which is why I said, actually, we're going to need significant growth going into next year in order to continue to meet needs. If you gave me an extra £10 million, would we spend it? Well, probably. But, you know, it's important that we meet needs. It's important that people are as independent as they can be. It's important that we don't create dependency on the council.
No, and I appreciate there's a fine balance in all of this, but when I look at that paragraph 28, frankly, I want to live in Derbyshire, where the gross spend on adult care is considerably higher than the gross spend on adult social care for Leicestershire.
Mr. Mayor.
Thank you, Chair. That's a nice last comment. Right, John, this report must have been difficult to write, and I don't envy any officer writing a report that's telling us we're £13.5 million and now potentially only £6 million overspent with 6 months to go in the budget. But it's important that we're realistic. I just want to point on two things. Why do you think there was an upsurge in February 2021? Is it demand that wasn't met during the COVID period and it's all come at once? That's firstly. And the second one, and rightly or wrongly in the press, it's been mentioned that actually adult social care is saving money because a lot of people, elderly people, have passed away during the COVID pandemic. And that this isn't evidenced here at all. And that's important to point out, I think. And then my final point is actually the social care precept of 1.5% or 1% on national insurance is going to kick in next year. Are we going to see any of that money in the early years, or is it all going to the NHS?
Okay. So take your last point first, because I remember that one. In terms of the 12 billion that will be delivered each year for the next 3 years through the national insurance rise, the first few years it will go to the NHS. So I think government have been clear about that. The social care reforms kick in 2023. So that's the point at which the funding will start to come into social care, probably from 23-24 onwards. But the majority of that money will, in the first 2 years at least, be directed towards the NHS because of the backlogs that they've got. There is a question I think most of us have, which is if you give £12 billion a year to the NHS for 2 or 3 years, how are you then going to take some of it out of the NHS to give it to social care? I'm not quite sure how that works, frankly. In terms of the early part of the question, which also relates to backlogs, what happened in February? I think a couple of things happened. The first is, and the biggest contributory factor was certainly the fact that the hospital started to run very, very hot. So they'd had the normal winter pressures kind of didn't happen last year because of COVID. So they had the COVID pressure, absolutely had the COVID pressure, and through December and January, you know, the second wave from a hospital perspective was much worse than the first, actually. And from from a care perspective, from a care home perspective. So the numbers of people who were in hospital due to COVID were in the 400s in Leicester in the second wave. But we didn't see some of the normal winter pressures. We didn't have a flu season. We didn't have other things that happen in winter normally, because everybody was at home, because everybody was isolating, because all sorts of things. And because we weren't treating people because of COVID. That did begin to start to take effect in February. So towards the end of that winter period, we started to see some of those things. So the demand, as the COVID demand went down, the demand from elective care shot up. And the hospitals began to be at the point where they were struggling to meet demand, and have, throughout the summer, have continued to be in that position. So the demand on urgent and emergency care is higher than it's ever been. People in July were talking about it being worse than the New Year in terms of the emergency department demand. We were getting, in Leicester has the busiest emergency department in the country, and they were getting 900 people a day going into the emergency department. They were getting 100 people an hour walking through the doors, all going in on ambulances. Ambulance services themselves were absolutely flat out and struggling to meet demand. All of that puts pressure on the back door of the hospital, which means that there's pressure then on social care and other services to discharge people as quickly as possible. So that demand started to ramp up in February, and it hasn't really, it's still there. It hasn't gone away in all of that period. There are very significant numbers of people who require elective treatments that haven't had those treatments for the last 18 months. I think, there may be issues around people being able to access care outside of hospitals that is contributing. But, that's just a personal view. And if the hospitals are under pressure, then social care will be under pressure, because we're part of the same system. And one leads to the other. And similarly, if the social care system collapsed, I'm sure that the heat would be felt in the hospitals. So, it's what happens in the system, isn't it?
Mrs. Broadley.
Thank you, Chair. Going back to the chart that Mrs. Wright mentioned, and that we're at the bottom of, really it needs another chart next to it, because although we are at the bottom of that chart, the reports on our adult social care and what we provide has been very good, and it's been reported as being good. I do say that the whole of this report brings into focus the fact that we are underfunded, and that hopefully some of our MPs will read this report and do more to get the fair funding that we've been fighting for years. But I do want to point out, really, that our adult social care, although we are providing what many would consider the basics because of the funding, and others can provide the jam on top of the basics, if you like, we don't do bad for what we spend. And I think that needs acknowledging. I'm not going to make a political point about the funding, because this isn't what this is about. But I do think that we ought to acknowledge the good work that the Adult Social Care Department and all its staff do, given the fact that we are so underfunded. And really, that's what I'd like to say. I just hope that things will improve for us, but that we continue to do the good work that I think this department does. Thank you.
Thank you, Linda. Anyone else? I'll just ask John, is there a disparity, do you know, between, because of the work we've done on keeping people living at home, do we have fewer people in residential compared to other counties and more people supported at home? Or do you know how that differs across, perhaps the people in that chart?
I could certainly find out for you. In terms of, I think I found it. I've managed to reload
Right,
it.
it keeps going, it keeps losing.
I do. Anyway, let's go again. In terms of Lincolnshire has a fairly similar profile to ours, but again, they are one of the lowest funded along with ourselves. Nottinghamshire and Derbyshire tend to have a slightly higher, well, they have more people receiving care than we do. The numbers of people who are in residential care compared to the numbers of people who are supported at home, I would have to look up actually for those two authorities. We do provide more direct payments than any other authority on the list, I think. Derbyshire, as an example, if you want to know kind of what you get for your additional monies, Derbyshire can afford to run upwards of 15 to 20 residential care homes directly that we can't run. And I would suggest that probably protects them to some degree from some of the increasing cost of residential care, because they are the biggest provider of residential care in East Midlands. They also have their own home care services that we don't have and other things. But in terms of, I mean, we could bring a report that kind of showed, well, there is a report actually. There's, as I said, this morning, the National Use of Resources report came out in draft form, and I believe that the National Adult Social Care Outcomes Framework data was published last week. So the next report that comes to committee that Matt Williams will bring on performance will have the 1920 data, and it'll compare Leicestershire with other authorities. And if we ask him, I'm sure he could put something in specifically around sort of Nottinghamshire, Derbyshire, if that's helpful.
It was really only interest of how we compare with the work we've done through the target operating model to keep people at home, etc. To sort of validate that. I suppose the second part of my question really was, when I read this, there was one bit that sort of worried me, and hopefully you'll put my mind at rest, but perhaps not, is that where we have fewer self-funders going into care homes, it's long been known that self-funders actually subsidise council. I think the right word, council paid for residents, and therefore is there a danger to us that the cost that we will be asked to provide could go up far greater than we might anticipate because of that lack of support from self-funders going forward, and what might that mean on the budget?
In short, the answer is yes. So I think, as it says somewhere in the report, going into the pandemic, around 20% of people that we fund would have had an additional payment that we would make. So we make two additional payments. One is called Supplementary Needs Allowance, which is where the person has additional needs that have to be met that wouldn't be met within the normal fee that we would pay. So we will pay a supplementary amount for those needs to be met. And then the second one is called a local authority assisted funding allocation, which is where actually there isn't any additional need, but the care home placement is just at a much higher cost, and therefore we have to pay an additional payment to source it. Around 20% of people would have had that previously before the pandemic, and it's now over 40%. So that's why the cost of care, I mean, that's when we say the cost of care is rising, it's those costs that are rising. So providers are saying, you know, yes, you can have a bed, but you can't have it at the £670 or whatever it was that you normally pay. We want £800. And why do they want £800? Well, partly because they have had some increase in costs. There's no doubt about that. It's more expensive now to provide care, IPC, PPE, workforce costs. The government has said that you can only employ these particular workers. You can't have. So all of that increases your cost base as a provider. But equally, it's because they've got high levels of vacant beds than they've ever had before. And because over the course of the last 18 months, residential care hasn't been attractive. If you're a self-funder, it's not the sort of place, you might be thinking of wanting to admit yourself because of the risks. So those providers, are seeking to maintain their level of income and their level of margin. And therefore, when we go to them and look for a bed, they say, yeah, you can have a bed, but it'll cost you extra money. And will those costs ever come back down? I think there has to be an adjustment, but it's probably somewhere between the two, isn't it?
Any further questions? Christine?
Mine's not a question. Mine's just to thank Mrs. Broadley for those kind words. And I'm sure the rest of the committee would say the same, how hard work they've been. I'm going to be talking to some of the staff on Friday morning, and I'll pass on thanks and the regards of the Scrutiny Committee along with my own, if that's all right. Thank you.
You preempted my comment, Christine. I was about to say, I think all of us support the comments that Linda's made. We know how hard the team have worked, and I think we're aware of the backdrop that John has starkly put out in front of us. And thank you for the report, John. I think it puts it there in black and white that we need to see with the budget round coming up, so that we know where this department is and what it might need to happen as we go through the scrutiny of the budget going forward. So thank you to that, and we echo what Christine and Linda have said. We're now on to agenda item 11, which is the update on the provision of community life choices services, pages 95 to 102. And you also have supplementary pages in a supplementary pack that was sent to you. I think John's going to kick off and then hand over to Heather Pick, the Assistant Director, and Zubair Patel, the Service Manager. I don't know whether they're here for questions or whether they're just going to add a commentary, but we'll leave you to start, John, and then hand over if you see appropriate.
Thank you, Chair. Well, I have done a lot of talking, so I'll hand over fairly quickly if I may. So I think both Heather and Zubair are on the call. So just to suffice to say that this is an update report. We brought a report to committee previously around two things. One, the procurement of community life choices, which are often referred to as day services. We went out to procurement, as we do every number of years, to find new providers. And alongside of that, we wanted to undertake a consultation on whether the council should continue to provide long-term maintenance community life choice services. So those two things have been running in parallel, and this is an update report to committee, which I'll hand over to Heather, possibly to begin with.
Thank you, John.
Carry on, Heather, in your own time.
Okay, so as John said, we're providing an update today on primarily the consultation that we've undertaken around the refocus of in-house services, but also an update on the procurement for community life choices providers. So from page 95 in your pack is the update on the provision of community life choices services. I won't go through the report in full, but would like just to highlight certain elements from that. So in paragraph 10, you read about the proposal of in-house services, community life choices, to refocus for short-term crisis care, reablement and enablement, and to enable us to provide a responsive 7-day services. Currently, community life choices in-house is a 5-day service, and to move away from long-term maintenance provision in order to refocus that and deliver the adult social care strategy. In paragraph 11, talks about the reprocurement of community life choices framework to include profound and multiple learning disabilities provision, and that framework closed to bidders on the 27th of September. To date, we've received 16 applications that focus primarily on services for PMLD service users. In paragraph 13, we've already seen a reduction for in-house services and a move to independent provision where that's available, and that continues. We started the consultation with 112 service users on our books for in-house, and currently we have 82 people who are still on our books. In paragraph 16, we highlight the 8-week formal consultation launched on the 31st of August. In paragraph 19, outlines the face-to-face and direct support to those that were impacted to enable them to have a voice during the consultation. And in paragraph 20, highlights the virtual team meetings with staff and others in order to have their voice heard and to help them through the consultation with both individual people that we support and with their family carers. We've included a supplementary report for you as a result of that consultation. What I would say here is that to the department and to the services themselves, the response is not surprising. We're undoubtedly very proud of the service that we've offered to date. We value our staff and we've invested a lot in training and support to enable them to do a good job. So I think it isn't a surprise to us that people value our services and would want them to continue. We are acknowledging that currently we've had a limited PMLD offer available from the independent sector, and the recent procurement seeks to address this provision. We have to say that we ourselves suffer from the same challenges that the independent sector market have: recruitment, service focus, costs of services, and long-term objectives for the in-house services going forward. If I could just go now to the supplementary report, which gives you a more up-to-date feedback of the consultation, which is now closed on the 26th of October, and the council received a total of 282 responses. Of those respondents, 67, equaling 24%, are either direct in-house people who use the services or a carer or relative of those people who use our services. Overwhelmingly, the majority of respondents strongly disagreed with the proposals for the council's in-house services to stop providing long-term day services. 90% of the current users of the in-house services and 83% of the total respondents. We've included the comments, some of the comments, not all of them, but some of the comments that we've had representative during the consultation to give you the context and flavour of those comments provided. We have had some good and bad responses, and you'll see them outlined. If I go to paragraph 7, half of the respondents strongly disagreed with the council's proposals to support existing service users to transition from in-house CLC services to new alternative provision. And in 9, the main reasoning for this was yet again the lack of capacity to deal with more complex needs of the individuals in our independent market. If we can then go to the update on the procurement, you will see that closed to bidders on the 27th of September, and we received a total of 37 tender responses. The majority of providers indicated an interest to deliver services to people with a learning disability and/or an autism. And of those 37 providers, just under 50% also indicated an interest in delivering services to people with profound and multiple learning disabilities. The tender responses have been evaluated, and we're in the process of award letters being sent out to successful bidders. So we are optimistic and fairly reassured that the independent sector market are looking to deliver services for our most complex people, and they're interested in that market. and we are interested in supporting them to do that. I think it's fair to say at this point that we aren't looking to totally finish in-house community life choice services, but we are looking to refocus that around our supported living provision, where we can offer a 7-day response that will mainly focus on crisis support, for carer support, and for those people who can learn or relearn skills to enable them to be more independent and therefore be able to rejoin that community life choices market in the independent sector where there is sufficient provision. I'm going to pause there for any comments, if that's all right.
Thanks, Heather. Mrs. Broadley.
Thank you, Chair. As you are aware, I am totally against the county taking away the maintenance of learning disabilities in their day services. I was interested to hear the reduction in service users, but I do feel that some of this is down to the fact that the county council closed their provision during the COVID crisis, whereas the independent sector didn't. And that because people had already had to have the change, and, you know, people with autism and different things do find change extremely difficult. So to go to one, then to come back, the upset would be horrendous for them. So I do think in some respects we did make a mistake of closing our facilities. The facilities that we run as a county council have been brilliant. I agree, the training for staff, the relationship that staff have with service users has always been really good. And I would hate to see that service gone totally. I think it could be amalgamated so that we perhaps don't have so many day services, but that we have smaller units. You know, we've got some big buildings. You can accommodate a couple of day services in at least one of the buildings that I know. I would hate to see the maintenance of it go. I really would. I think that it would be a mistake that we would be making. These people rely on us, and some of the independent sector, which I'm hoping that during this consultation or whatever you want to call it that you've put out to them, I know of day services in the independent sector that I feel, after working in learning disabilities for many years, have taken the service back 20 years. There are day services now where people go and they sit and they do colouring, they do jigsaws. They don't have the same interaction with the community that they do with Leicestershire County Council. And I feel very proud to have worked for the Learning Disability Service, and I think personally it will be a big mistake for us to lose it. Thank you.
Heather, do you want to respond?
Well, just to say thank you for your kind words. As I said in my presentation, we are also extremely proud of our services. We do recognise, however, that we do need to try and refocus our services, and we do want to support the market. What we have seen in the past is a number of our day services managers and social care staff leave adults and communities and set up in the independent sector. So they're well aware of the issues and the needs of the people that we support. I said previously as well, our intention isn't to not provide these services, and we would always want to offer support to those in crisis or for carers who maybe their current provision is not suitable and while they're transitioning. So, you know, I echo what you're saying about in-house services, and would want the support of the committee really to support the independent sector where we can to develop and grow that market.
Does anyone else wish to comment? So I think, are we a committee broadly in agreement with the paper that's been put forward and the direction of travel? I think we certainly hear from what Mrs. Broadley's saying, and I think we're reassured by your comments, Heather. But I think the committee, generally speaking, I think a majority in favour of the direction of travel that this paper indicates. So thank you for that.
Thank you.
We're now moving on to the final agenda item today, which is a report on the mandatory COVID vaccination for workers in care homes paper on pages 103 to 110, which I think is John's going to introduce, then Kate Revel, Head of Service for Commission and Quality, will be taking over, or is here to answer questions, one or both.
Thank you, Chair. I think on this instance, I'm going to hand straight over to Kate, who has done an awful lot of work in this area and has much more information than I do on this. Kate.
Thank you. What I'll do is I'll take you through the key parts of the report. So the purpose is to explain the work that Leicestershire care home providers have done with the challenging new requirement around mandatory COVID vaccinations for people working in care homes, and how the council has supported them to do that. The committee will be aware that in July it was formally passed that from the 11th of November, so in other words, from where we're standing today, next week, there would be a 16-week lead-in period for unvaccinated workers to have first and second doses before a full implementation date of the 11th of November, at which point all workers within care homes and anyone visiting care homes on a professional capacity would need to have had a full course of an approved COVID vaccination. So there has been a huge amount of work that provider colleagues have been doing to prepare their staff and their services to ensure that they're going to be compliant with the new regulation from next week. This committee has received a number of papers over the last year or so around the challenges faced by care homes during the COVID period, and previous reports have mentioned vaccination and have given the history to vaccination within Leicestershire, which began in December 2020, so almost a year ago now. The authority has done a huge amount with providers who have worked tirelessly with their staff groups to encourage them and support them to take up the COVID-19 vaccination. And the sorts of things that we've done with public health colleagues in support to the market have included question and answer sessions. We've produced publicity materials and frequently asked questions documents, including those tailored for Leicestershire, communications for specific communities. We've promoted provision of vaccination sessions at times and locations which are convenient for adult social care workers and for care home providers. Adjustments for people who are needle phobic. We've instigated a vaccination inquiry webpage, an inquiry service. We've delivered weekly updates to providers, and for the last several weeks, if not months, every edition has included some element of mandatory vaccination support for care homes. We've done targeted work for areas of particular hesitancy, such as pregnancy, and public health colleagues have produced and promoted what they've called a Healthy Conversations toolkit for managers and a care home manager resource pack for mandatory vaccination. In terms of legal and HR implications, external providers have needed to seek their own professional advice on that because, of course, contractual matters will be specific to the provider. From an internal perspective, the authority's policies and procedures have been drafted in line with government guidance and our own internal legal advice, and will be continually kept under review as things develop. In terms of our understanding of risk associated with the care home mandatory vaccination requirement, for the past several months, we've undertaken detailed work across all operational independent care homes in Leicestershire, and there's about 167 of those, to allocate what we're calling a RAG, or a red, amber, green risk rating to each home, focused on the likelihood and impact of a reduced number of staff being able to work within that setting. There's a number of things that we've used to determine that RAG rating, which you can see in paragraph 14. What I've got for you today is some updated data, because of course this report was finalised a couple of weeks ago. The risk ratings per care home provider can be seen in paragraph 15, and as of today, the number of care homes within each risk rating bracket are 2 red homes, 12 amber homes and 153 green homes, and the 2 red homes are for working age adults. We've done a whole series of interventions which we've used with the red and amber risk care homes, so in other words those with the higher risk of some service disruption. We've encouraged detailed discussions with GPs where there are particularly where there are culturally relevant matters to discuss. Staff focus groups, including behavioural science methods promoted by public health colleagues, manager training in Healthy Conversations toolkit. Our Inspired to Care team has provided hands-on support with recruitment and retention. As we move towards next week, there's increasing focus on what providers' business continuity planning arrangements look like, and we've been critiquing and supporting with development of those. And signposting to specialist resources, including the council's internal policy and bespoke procedures for managers, as well as recognising that there are wellbeing concerns for staff who are particularly hesitant, and signposting where required to support services there. In terms of professionals entering care homes from other settings, we have provided support to care home businesses again to encourage them to work with their suppliers and tradespeople entering their settings, who might include hairdressers, including health colleagues, of course, GPs, community nurses, etc., who also need to be fully vaccinated from the 11th of November. And health colleagues have also, from the other end, done lots of work to ensure that only fully vaccinated staff can be deployed to care homes and can evidence their vaccination status. From internal services perspectives, there are, of course, a number of roles within the County Council who, in the course of their daily duties or periodically, might need to enter care homes. And some of those professions are listed in paragraph 19. We are now at the position where 5 workers within the authority continue to be supported by managers and HR around increasing their confidence in the vaccine. So we are talking about a very small number of employees, and a further small number will be exempt on medical grounds, and the council's vaccination policy has been revised to take that into account. I won't talk in detail about medical exemption from vaccination, but there is currently a temporary medical exemption provision in place pending the deadline of the 23rd of December, at which point everybody who considers themselves to be medically exempt needs to have spoken to a GP and had it confirmed by the GP or other specialist clinician. Those temporary self-certifications fall away on the 23rd of December, and only medically confirmed exemptions will stand from that point. I've spoken a little about business continuity planning, and we continue to support the sector with that. And we've increasingly during the pandemic learned more about potential indicators of unstable care home provision, and that's helped us to develop further a multidisciplinary approach to supporting care home providers where they are unstable. And we do have a mutual agreement in place where health and social care partners come together to ensure that people are cared for safely in the event of significant provider disruption. Just to finish off, there is a consultation on mandatory vaccination of health and wider social care staff, which was in place nationally and finished to submissions from respondents on the 22nd of October. The council responded to that consultation to indicate that, of course, additional protection from infection for people who use adult social care services to be welcomed, and the council promotes a position of strong encouragement for vaccination. The impact on the workforce is likely to be severe if a mandatory requirement is brought in. We know from our experiences with care homes that some workers are not willing to take up the COVID vaccination, and that may lead to people leaving the market completely where they work within home care or other relevant services. We continue to engage with providers around this challenging new requirement, and we will do the same for the wider adult social care market if that current national proposal is actually brought in. And we're doing a huge amount to support providers in mitigating their risks around the requirement. So in conclusion, this is a theme that the committee will have picked up on significantly over the last 18 months or so. The care home market has been substantially impacted by COVID-19, and the mandatory vaccination requirement has brought an additional challenge. But we do feel, moving to the 11th of November, that we're well placed to meet the regulations, and the vast majority of the workforce have now completed a course of an approved COVID vaccine. So the committee is asked to note the contents of this report, and also the fact that the national consultation on extending that requirement to the wider health and social care workforce has just closed, and we wait to hear the result of that consultation.
Thank you, Kate. Any questions? Mr. Mayor.
Okay, thank you very much. That's a very reassuring report, and I presume that the chart that you've given to say the percentage-wise of vaccine take-up has probably increased, because this report would have been done a couple of weeks ago, especially for the vaccine too. But it still leaves a little bit of a gap. Even 5% to 10% gap in the workforce is still in the care sector that is struggling to recruit a substantial gap that they probably didn't need at this moment in time, especially with what's going on in the wider economy, with everybody competing in a shortage of labour market. So what does that 5 to 10% represent in numbers wise? Do you know?
I can give you the very updated figures from the workforce. If you consult paragraph 10, the figures taken from our dashboard today show that for Leicestershire care home staff, dose 1 take-up is now 94.6%. And for dose 2, so that's completion of an approved COVID vaccination course, is 88.7%. And we know that there are still a significant number of people who over the next few days will be getting that dose 2, because there was, as you might imagine, a flurry around the deadline for the first vaccination. So as we know, and as you've identified, that is the vast majority of care home staff having looking to have completed their course of a COVID vaccine by the 11th of November. But there is a gap, as you've identified. And for us, at this point in time, I think it's less about that absolute figure, the 94.6% or the 88.7%, and more about care homes' ability to respond to the residual challenges that leaves them with. And the sorts of things that we've been working with the higher risk providers on are looking at, for example, their recruitment and retention efforts. We know that some providers are regrettably needing to work with staff to exit them from their organisations because they're not confident enough to take up a vaccine, and consequently to undertake recruitment and retention, so that we know that for the red and amber homes, and to a certain extent the green homes as well, they're doing a significant amount to ensure that they have recruited staff and that they can retain staff. We know that for the red homes, they have increased wages to attract more recruits, for example. They've undertaken interviews which will ensure that staff can onboard as soon as possible. They're looking at how they might restrict admissions, for example. So the sorts of impacts that we're looking at this point in time don't appear to be significant provider failure. It's more about restricting admissions to new people and to look to agency block booking of staffing, for example, which will have a financial impact, but in the short term will ensure that people are kept safe.
No one else, just a couple of little quick ones from me. Just interested, the temporary exemptions, which you said run to something in December. I just wonder why we didn't match the date up for the 11th of November, it would seem to me, because presumably those people won't be allowed to go in care homes after the 11th of November on a self-certified basis, or are they? And why would we let unvaccinated self-certified people go in care homes, which strikes me as a major risk? And then secondly, you used the word, when you responded to the NHS consultation, I think you used the phrase challenging to take the vaccine. Now, on the basis that a lot of healthcare staff have to have hepatitis B, yellow fever, etc., it slightly concerns me that if we say it's challenging to take COVID, we're therefore, by implication, saying it's challenging to take hepatitis B or yellow fever, etc., which would strike me as the wrong message to send into the health service.
I'm sorry, would you mind repeating the first question?
Why didn't we make the temporary self-certification exemptions? I think they've got until the 20-something of December.
The temporary arrangement and the permanent arrangement have both been nationally set. Right. And I think the slight awkwardness of the two overlapping arrangements were simply that it took central government a while to work out how they would ensure that people could medically exempt where they had a genuine need to in time. We also know that there were some they also wanted to do further thinking around pregnancy. We know that although the COVID vaccination is safe to take within pregnancy, it's clear from the data that pregnant women are or can be hesitant to take up the vaccination during pregnancy. And that was another reason for instituting a temporary exemption, and people can still claim a temporary exemption on the grounds of pregnancy beyond the 23rd of December, but that would have to be signed off by a relevant clinician. So it is recognised that those deadlines for, firstly, temporary self-exemption and secondly, having the permanent arrangement in place for medical exemption, which comes in on the 23rd of December, are rather clumsy. But I think it just reflects the fast-moving nature of the development of this work and the point at which the NHS and Department for Health and Social Care have been able to release the relevant processes. On the second point, the point relating to the, sorry, just bear with me a moment, the consultation on mandatory vaccination of health and wider social care staff. The substance of the council officer's response to the consultation is given in paragraph 31. So we do recognise that this is a challenging requirement for the care home sector. I think care home sector colleagues would agree with that position. It has presented them with recruitment challenges, and that is also likely to be the case for home care and other adult social care providers. Recruitment and retention within adult social care is a key concern at present. We know that there's been a reduction in workers from overseas and that there are competing industries with adult social care now that certain industries have opened up again following the height of the pandemic. We see that people are attracted to hospitality, to retail, to warehousing in some circumstances, and even a small number of workers who are not confident in taking up the vaccine might compromise the ability of providers to deliver services. So really any disruption or change which might affect recruitment and retention, we know will be a challenge. So that's the reason for the use of the word challenge within that paragraph.
Sorry, it wasn't within that paragraph. I think it was when you said we'd responded to the consultation on NHS service workers. Unless I misheard you or misunderstood.
The proposed extension of mandatory vaccination will apply to health and all remaining eligible relevant social care workers. At the moment, the mandatory vaccination requirement applies only to care home workers and to workers who have to enter care homes during the course of their work. That might be social workers, and that will be community nurses, for example, GPs.
I think I've misunderstood. You've misunderstood the point. What I'm saying is, if it's challenging to take a COVID vaccination, why is it not challenging to take yellow fever or hepatitis B, etc.? And if we therefore say one is more challenging than the other, why is it more challenging than mandatory inoculations that quite a lot of national health workers already have to take? That's the bit I didn't understand why we said this one is challenging. If we're saying this is challenging, taking hepatitis B must be challenging, but we've not made that comment.
Yeah, forgive me, I don't know a great deal about hepatitis vaccination within the health service. I do know that that is present, and that was one of the precedents, I guess, that was set, that was referred to when care home worker vaccination was initially mooted, that there had been a precedent set within health services. I guess the difference is that it is until next week untested within adult social care services. If somebody is going into a particular eligible health profession where that type of vaccination is required, they're going into that with their eyes open. They know it's going to be mandated. They know it will be within their contract. What we're doing here is retrofitting, if you will, mandatory vaccination onto a workforce where we know there are already recruitment and retention challenges, and where that was not an expectation when they first entered their role. I suppose that's the difference.
Okay, thanks, Kate. Any further questions? Now, you'll be pleased to know, everybody, we've reached the end of the agenda. So you have the dates of the future meetings, all of them for 2022. Next one being on the 24th of January. I said there are no urgent items, so thank you all very much for attending today's meeting and contributing so fully. Thank you all.